Welcome to The Explainer. Today we're going to talk about a tool that is seriously changing the game in how we stage liver disease. We're moving beyond that old-school biopsy, and to do that, we're going to lean on the latest AASLD practice guideline to get you completely up to speed.
Okay, so here's our game plan. First, we'll talk about why we even need to move past the biopsy. Then, we'll get into the nitty-gritty of how we measure liver stiffness. It's pretty cool. After that, we'll look at the different tools you'll actually see in the clinic, some really critical pitfalls to watch out for, and we'll wrap it all up with a super practical algorithm you can start using.
You know, for decades, if you wanted to know how much scarring was in someone's liver, the liver biopsy was it. It was the gold standard. It lets you look right at the tissue, but man, it's invasive, it's expensive, and it definitely has its risks. So this is the million-dollar question that really pushed the field forward. We know that catching and staging chronic liver disease early is absolutely key to preventing bad outcomes like cirrhosis or liver cancer. So the hunt was on for a better, safer, and just plain easier way to do it.
And when you put them side by side, the difference is just staggering. We're talking about going from a painful, risky procedure that samples a teeny tiny fraction of the liver, like less than 1/50,000th, to a totally non-invasive tool that gives you a snapshot of a volume that's at least 100 times bigger. It's a huge leap in getting a true picture of the whole organ.
All right, so how does this technology actually work? It's a really brilliant piece of physics that gives us a direct physical measurement of the liver's health.
The key concept you gotta wrap your head around is liver stiffness measurement, or LSM. We're not looking at lab values here. We are physically sending a tiny vibration, a shear wave, through the liver, and we're timing how fast it travels. That speed, which we measure in kilopascals, tells you exactly how stiff or soft that liver tissue is. And the principle behind it is so intuitive, right? As scar tissue, fibrosis, builds up, the liver gets physically harder and stiffer. So a wave is just naturally going to travel way faster through dense, stiff tissue than it does through soft, squishy tissue. More speed means more stiffness, which usually means more fibrosis. Simple as that.
Now, when you're out there in clinical practice, you're going to come across a few different kinds of elastography. They're all based on that same idea of measuring shear wave speed, but they each have their own way of doing it. So let's break down the main tools in your toolkit.
So this table really breaks it down. First up is transient elastography, or TE. This is the one you'll probably see the most. It's quick, great for point-of-care screening. Then there's shear-wave elastography, or SWE. This is actually built into ultrasound machines, which is awesome because it lets you see where you're measuring and avoid things like big blood vessels. And finally, you have the heavy hitter, MR elastography, or MRE. This uses an MRI, it assesses the whole dang liver, and it's the most accurate. But it's also way more expensive and not available everywhere.
But, and this is a really big but, these tools are not infallible. As a trainee, it's so important to know that the number you get is not the whole story. You absolutely have to know what else might be making that reading falsely high.
If you take away one single thing from this, let it be this. A high stiffness reading does not always equal advanced fibrosis. The test measures stiffness, not fibrosisness. That number is just one clue, one piece of a much larger clinical puzzle.
So here are the usual suspects, the things that can really throw off your reading. Acute inflammation, like when someone's having a big hepatitis flare, makes the liver swell up and get stiff. Same goes for when the liver is congested because of something like heart failure. Heck, even just eating a meal can temporarily raise the reading. You have to have these in the back of your mind every time. And look, the guideline is crystal clear on this. If your patient's liver enzymes are going wild, their stiffness score is just not going to be reliable for staging fibrosis. So the rule of thumb is simple. Always interpret that score in the context of the patient's labs and the entire clinical picture.
Okay, so with all that in mind, how do you actually put these tests to work to make decisions for your patients? The guidelines give us a fantastic, simplified algorithm. Let's walk right through it.
This four-step path is basically your playbook. You start simple, with blood tests like the FIB-4, just to get a general sense of risk. For anyone who isn't clearly low risk, you move on to elastography to get a real stiffness score. Then, you use some validated cutoffs to interpret that score, and that tells you what to do next, like whether you need to start screening for varices. So let's talk about those all-important thresholds. First up, for most liver diseases, a score under 8 kilopascals is really reassuring. It has a great negative predictive value, which means it makes advanced fibrosis super unlikely. Think of it as your rule-out number.
Now, when you start creeping up into that 12 to 14 kilopascal range, that's when you should get concerned. This is the zone where your suspicion for advanced fibrosis needs to be high, and you start thinking about what that means for managing your patient long term.
And finally, a reading of 15 kilopascals or higher, well, that's highly specific for cirrhosis. When you see a number like this, especially when it fits with the rest of the patient's story, that's your green light to start managing for cirrhosis. And that means screening for portal hypertension and for liver cancer.
So we'll end with something for you to think about as your careers unfold. Look, the liver biopsy will probably always have a role for those really tough diagnostic questions. But for just routine fibrosis staging, its role is changing fast. As these non-invasive tools get even better and more widespread, we might just be seeing the beginning of the end for the routine biopsy. Thanks for joining this explainer.